So let's talk about psoriatic arthritis. It's one of those really complex medical conditions that can be a real puzzle to diagnose and even tougher to live with. But like any good puzzle, if we look at the clues and piece them together, we can absolutely solve it. So today, we're going to be detectives. We're going to piece this whole thing together.
All right, I'm going to start with just a number, 20%. Let that number hang in the air for a second. What in the world could that mean?
Well, it turns out that's the number of people with the skin condition psoriasis, about 1 in 5, who will go on to develop something called psoriatic arthritis, or PSA for short. And let me tell you, this isn't just a minor ache and pain. We're talking about a hidden, often aggressive disease that can seriously mess with your quality of life if it's not caught and treated.
Okay, so let's jump into our first section. The first piece of our puzzle is this fundamental link, the connection between what's happening on your skin and what's going on deep inside your joints.
So what is it exactly? Well, here's the official take, and you got to pay attention to two words here, chronic and inflammatory. This is not your typical wear and tear arthritis. Nope. This is a systemic disease, a case of friendly fire, where your body's own immune system gets confused and starts attacking itself, causing inflammation in your joints and a whole lot more.
But here's where it gets really tricky, and you can see it on this slide. The timing is everything. For most people, yeah, the psoriasis shows up first. That's a huge clue for doctors. But look at this. For about 17% of people, the arthritis hits before any skin rash ever appears. Can you imagine trying to solve that puzzle? It's like starting with a key piece missing right from the get-go. All right, so we've established the link to psoriasis. That's our first big clue. Now for section 2, we need to ask the big question, why does this even happen? What's really causing it?
Well, the best science we have right now points to this kind of two-hit combo. Think of it like this. Your genes are the wiring for a super high-tech but kind of glitchy security system. Then some environmental trigger, maybe an infection, maybe an injury, comes along and acts like a burglar, tripping the alarm. But here's the problem. The alarm system is faulty. It just won't shut off. And that constant blaring, that's the chronic inflammation.
And if we look closer at that genetic wiring, it gets even more specific. You can see here that different genes are linked to different flavors of the disease. For instance, if you have the HLA-B27 gene, you're more likely to have issues with your spine. This is so important because it tells us that psoriatic arthritis isn't just one thing. A person's own genetic code can really shape how the disease shows up in their body.
So what about those triggers? What's the burglar that sets off that faulty alarm? Well, infections like strep throat are a big suspect. Another one is physical trauma. In psoriasis, if you injure your skin, a new patch of psoriasis can pop up right there. They call that the Kubner phenomenon. Well, researchers think a similar thing might be happening on a deeper level, a deep Kubner phenomenon, where an injury to a joint could be the very thing that kicks off the arthritis.
So, when the immune system goes haywire, what is it actually attacking? This right here is the absolute core of what makes psoriatic arthritis so unique. The main battleground is a place called the enthesis. That's just a fancy word for the exact spot where your tendons and ligaments connect to the bone. Inflammation right there, that's called enthesitis, and it's the absolute hallmark of this disease. It's a huge clue that helps doctors tell it apart from other kinds of arthritis.
Okay, that brings us right into our third section. Because this disease can attack the body in so many different ways, it's a bit of a shapeshifter. It can show up with a lot of different faces. So let's look at the 5 classic patterns that doctors look for.
And wow, you can see just how different these patterns can be. Sometimes it's asymmetric, hitting just a few big joints. Other times it looks a lot like rheumatoid arthritis, affecting many joints on both sides of the body. It can even target the spine or those tiny little joints at the tips of your fingers and toes. And then there's the last one, arthritis mutilans, which is thankfully rare, but it's the most severe and destructive form.
And this X-ray, just look at it. This shows you exactly how destructive that form can be. You can see the severe bone erosion, the joint damage. It's a really powerful reminder of why getting diagnosed early and starting effective treatment is just absolutely crucial. It's all about preventing this kind of permanent damage.
Okay, so besides those 5 main patterns, doctors are also on the lookout for other classic telltale signs. One is something called dactylitis, which is a big word for when an entire finger or toe swells up and looks like a sausage. Yep, a sausage digit. And another huge clue is nail disease, things like tiny little pits in the nail or the nail starting to lift away from the skin. For a doctor, those are huge red flags. So we've got all these clues, right? The skin, the genes, the specific patterns. How do doctors take all of that and put it together to actually make a diagnosis? Well, that's what we're covering in this next section.
Okay, this is maybe the single most important thing you need to know about diagnosis. There is no one magic blood test for psoriatic arthritis. You can't just go in, get a blood draw, and get a simple yes or no. The diagnosis is what we call clinical, which means it's based on a doctor's examination and a careful collection of all these puzzle pieces we've been talking about.
Now, to make this whole process more objective, experts came up with a clever scoring system. It's called the Caspar criteria. Here's basically how it works. First, you have to have inflammatory arthritis. That's the starting point. Then you start collecting points. Have psoriasis on your skin right now? That's 2 points. Nail psoriasis? That's a point. A sausage digit? Another point. And here's a good one. A negative blood test for rheumatoid factor also gets you a point. If you rack up 3 or more points, boom, that confirms the diagnosis.
And a huge part of this diagnostic puzzle is telling psoriatic arthritis apart from its more famous cousin, rheumatoid arthritis, or RA. This chart lays it out really well. PSA is often asymmetric, meaning it doesn't hit the same joints on both sides of the body. It also loves to attack those little joints at the ends of your fingers and toes, which RA usually leaves alone. And like we just said, that key blood test for RA, the rheumatoid factor, is usually negative. And of course, there's the big one, that inflammation at the entices.
All right, let's move into our final section. And honestly, this is the most hopeful and exciting part of the puzzle, how we treat this disease today. It's all about a modern, proactive strategy. You see, the goal of treatment today is so much bigger than just temporary pain relief. It's a full-on mission to control the symptoms, yes, but also to stop any structural damage in its tracks, and ultimately to let people live their lives to the fullest.
And the good news is, doctors have a whole arsenal of tools to make this happen. It all starts with the basics, things like physical therapy, exercise, and quitting smoking. From there, we move into medications, from traditional drugs like methotrexate all the way up to these incredibly advanced medications called biologics and targeted synthetics.
And what's so incredible about these newer biologic drugs is just how precise they are. They're not like the old sledgehammer approaches that suppress your whole immune system. No, these are more like smart bombs. They are designed to go in and target the very specific proteins and pathways, like TNF or IL-17, that are actually causing all the trouble.
And this all fits into a modern philosophy of care called treat to target. The whole idea is simple but powerful. You and your doctor set a clear goal. Maybe it's total remission, or maybe it's just getting to the lowest possible level of disease activity. Then you're monitored regularly, and your therapy is adjusted as you go, all to make sure you hit that target. It's a really dynamic, personalized way to manage the disease.
So there you have it. We've pieced together the psoriatic arthritis puzzle. We've looked at the clues, the link to psoriasis, the genetic and environmental causes, its many different faces, and the amazing modern treatments we have today. So I'll leave you with this final piece, this final question to think about. Now that we understand so much more about this disease, and we have this arsenal of targeted treatments, how can we change the future for a condition that was once just seen as a minor complication? The clues are all there. Now we just have to use them.